Okay, based off your patient's irritability and severity, it will depend on whether you do a full versus limited cervical exam. So there are times where I may defer from the seated examination and go directly to getting the patient into a comfortable position if their symptoms and their irritability is somewhat elevated, specifically usually if they rate it 7 out of 10 or more at rest. Then going about moving the range of motion, etc., or if they have like persistent radiating symptoms or shooting symptoms down their limb, really the necessity is to try and get them as comfortable as possible. Assuming that we're doing the full physical exam, or they can tolerate this, I'd get the patient in supine. Depending on the patient's kyphosis of their thoracic spine will necessitate how much elevation or depression you put as far as the angle of the head of the table. Notice that I kind of pulled the pillow out from underneath her cervical spine so that the weight of the head is not in my hands, but rather supported by the pillow. And then, sorry for the cold hands. Now my hands are much more able to feel the neck versus actually holding the weight there. So first, I'm going to stick with the SFMA breakout for a moment as far as what we saw in sitting. So we know that rotation is not good to either side. What we don't know is whether this is going to be upper versus lower cervical spine restriction. We know that C1, C2 has about 40 degrees and accounts for up to 50% of the rotation. So given the bilateral nature of it and the fact that that's one level that accounts for 50% of both, we're going to start there. So we'll start with OA, so starting on the occiput. So if we rotate as far as we can, not to the painful range, are we okay there? Mm-hmm. Great. And then we're going to have her nod, okay? And we're looking for 20 degrees or so, okay? And that's pain-free, and she gets the range of motion. Is that accurate? Mm-hmm. Great. Other side. Same bit. Okay. So she gets the range of motion on both sides. What I like less is that she actually lifts when she nods versus getting a pure nod, which speaks to potentially some restriction at the OA joint, but her range of motion is sufficient. And it's pain-free, correct? Mm-hmm. Yeah, great. So then next segment is your C1, C2. So we're going to just do the exact opposite. So if we're thinking about the mechanics, with OA being more of a yes-no joint, then we rotate to take up the slack, and then look at the yes-no. And then with the C1, C2 being more of a kind of your rotation component, then we're going to flex up. So take up the tissue slack in the other plane. And I'm going to use my chest or my body, my torso, to support the weight of the neck. And then just cueing her to relax here. Perfect. Any symptoms before I begin? No. Okay. Again, as I mentioned, we're looking for at least 45 degrees. Any symptoms there? No. Great. And then other side. Any symptoms there? No. Okay. Yeah. So moves well and also not painful. And then we move down to the lower cervical spine. So we'll have you go ahead and rotate as far as you can. And we're looking for 70 degrees. She doesn't get it. Can you go any further? She can strain to get there. Any symptoms with that? No. Not convinced. All right, so uncomfortable. Tight. Yeah, so stiff, but not painful. Okay, other side? Anything there? No. Great. And she gets that. Cervical extension. I usually don't check this one. Usually just it's not limited. So you support the weight of the head, drop the head of the head. And then we're looking at it passively. Go ahead and relax. Great. And she should passively extend. This was if she had restrictions in sitting, which she didn't. It was all good. You pull it back up. Very good. Okay, so range of motion seems to be just fine when we look at it passively and we break out the segments. Now we have to go through, we still know that she has pain. It could be just postural based, meaning like her neck moves differently in sitting versus in supine. But what we need to sort out is whether that's actually the case, and so we'll go in and do a closer biomechanical assessment. So we'll start at the top and work our way down. So OA, right? Do the condyles come up? Yes. Do they go down? Yes. Do they side glide? Yes. Do they side glide? Yes. So OA looks to be pretty good. If we go at 1, 2, so same bit, doesn't have as much extension and flexion here, but we'll check it all the same. And then we go lateral glide. No, she doesn't like that, and definitely doesn't like that. So there's our accessory motion restriction there, despite her demonstrating sufficient movement. Okay, and then we would do that segmentally all the way down. Does it flex? Or sorry, does it extend? Does it flex? Side glide, side glide, side glide left, worse than side glide to the right. And I'm being quite mechanical in nature. In real time, it would feel less pokey and it would feel like this, where I'm checking all the planes of rotation and side glide simultaneously. And both hands are working together, almost like I talk about like the moonwalk. It's kind of like how I imagine it with my hands as I'm walking down each level. It should be relatively comfortable for the patient. Yeah.
Yeah.
Great. All right, but so that is uncomfortable, and so is that, but it's worse on the right.
Mm-hmm.
Would you agree?
Yeah.
Yeah. Okay. So we can see at C1, C2, and maybe even C2, C3, there's some restrictions, right being worse than left. And that cues me in, okay, that's what I need to treat, and at this time point, I would go in and treat that. But we're going to continue on with the assessment itself. So then other things that I look at from like a joint standpoint, and sometimes you can't get to the joint mobility first because of the amount of tone that someone is in. So I often will do a lot of breathing with suboccipital release and first rib mobs as a means of helping to reduce the tone, get the person comfortable, relaxing the central nervous system before I actually go in and do the assessment that I just demonstrated. So first rib, I'm going to side bend, rotate, press. So the first rib comes right up into my thumb there. I can't tell if it's restricted, but it seems stiff to me. If I come to the other side, yeah, there's definitely a difference. Consistently more so on the right than on the left. Would you agree? Yeah. Okay. So then that would be another point that we could consider treating, not only manually, but then also reinforcing it with like a first rib mode for home or something of the like. Great. I'm just thinking of what else I've forgotten. Okay, other palpation or pinpoints. So I could come upper trap and I'd strum in the upper trap, looking for potential trigger points. I would also come down the levator and kind of strum it as it goes from the upper 4 levels of the cervical spine down to the corner of the scapula, knowing that based off Simon's and Travell's trigger point, right? So there's going to be a trigger point most often, or most likely right at the connecting point, and then halfway up, right at the twist of the levator. Otherwise, you can also consider scalenes, right, where I'm actually kind of strumming through. I don't differentiate. I could, and I'm sure that some people are more specific than I am. I'm just like, is there tone there? Is there not? Does that elicit their consistent symptoms? Along the SCM, so I'll usually as soon as I side bend or rotate and side bender, it pops, and then I never go ahead and relax. Great, but that helps me find it immediately. And I'll go through and pinch it, particularly if people are having cranial-based pain, pinching through here and trying to re-elicit that and really rule in or rule out what the contributing factor is of their cranial-based pain from their cervical spine can be somewhat challenging. This is one way that you can go about doing so. Gwendolyn Jull also talks about the upper cervical spine referring into the cranium, and with your cervical genetic-based headache, she's done a considerable amount of work. Her last name again is Jull, Jull. And when she's looking at diagnostic criteria, she's looking for hypermobility within the cervical spine, the presence of a headache, and then Also, like if I push on this region, whether it actually elicits some of those symptoms. She also describes like the flexion rotation test that we did previously. Tati has great joint mobility in general, and so she's actually able to hide the dysfunction that she has at the C1, C2 level. But those are other considerations when you're looking at, is this headache associated with the cervicogenic based origin. Upper limb, so great. So that's like essentially my biomechanical assessment for the cervical spine. I would also look at potentially upper back mobility, and so this would be joint play assessment, which gets beyond the scope of this video in particular, and then also looking at like the child's pose where they're actually rotating. We want 50 degrees side to side. If Tati complains about history or current symptoms past the AC joint, any paresthesias, tingling, anything within the upper extremities, then on day one, a neuroscreen is necessitated, and that would be one of the first things that I do, and I'll do it prior to doing a neurodynamic, because if it is indeed a pinched nerve within the neck, then doing neurodynamics will potentially piss it off even more, and then we'll move into our neuroscreen.